really give a talk again. We are really starting with basics. So the basic talk is really going through the basics of transcranial Doppler. You can practice to pronounce my name, Zsolt3. If you say Zsolt close enough, if it goes to the other direction, Joel, that it's fine, but it's Zsolt. Practice like Zsolt3, okay, and that will be close enough. During the lecture, guys, anytime you can say, I'd like to ask a question, because the whole idea is that we're really doing slowly, so make sure you capture all the basics. When after the lectures we'll have a hands-on session, you're able to do the test after 2 hours of training you by yourself. So we'll have 2 TCD machine and 2 transcranial color-coded duplex machines in our clinic. So it's not just a dry, boring lectures, but we'll have some hands-on after these talks. So I like to call transcranial Doppler as a stethoscope to the brain. Hold on, just need to check something really fast. And so the stethoscope to the brain is really a fancy name, but it's truly trying to insonate the intracranial vessels. And I'm fighting a lot with doctors who are sending patients to here, and they are telling patients that is impossible to go through the bone and do an ultrasound. So those are the doctor or cardiologists who are really would like to do everything. They definitely don't know where the border of the heart. They definitely go to the leg, they go to the carotids, and I think very important then when someone works with different vessels, the anatomy will be number one. So you'll need to be strong with anatomy and the basic abbreviations. That's the sadness of the medicine. But middle cerebral artery, that's MCA, ACA anterior cerebral artery, PCA posterior cerebral artery. So that's what you're going to see through the temporal bone window. Through the orbital bone window, you're going to see the ophthalmic artery and a different part of the internal carotid artery. So that's another news that when you do carotid duplex, the carotid duplex is not really doing the whole segment of the carotid artery, just probably 1/3 or probably half of it. So almost when you do a chest x-ray, you just do the half of the chest, and the other half you would just kind of guess. Through the occipital window, via the foramen magnum, we can see the vertebral and the basal arteries. And the last one, the fourth, the submandibular approach, we're using it most in NICU. After subarachnoid hemorrhage, we would like to see the ratio between the intracranial and extracranial velocity of the ICA or the MCAs. This is when we are doing the submandibular. Otherwise, we like to use definitely the duplex technology to see the extracranial internal carotid artery. Again, anatomy, yeah, you need to figure out, and all those fancy variations you can run into. Probably if you've been on one of our Fridays lectures in the morning, we showed you how the vertebral can come up from the internal carotid artery, how the both carotids can come from one source. All these different variations kind of helps you to understand. But very important to have a clue about the intracranial circulation, how the intracranial circulation getting the flow. And this way you have to imagine the whole brain having 100% of the blood flow delivered by the 2 carotids and the 2 vertebrals. The 2 carotids going to deliver 40% on each side, and the 2 vertebrals about 10% the whole volume. So if you're one of the carotids stenosis occluded, you're going to have that 40% redistributed from the other side of the carotid or the vertebrals. But those are the things why you need to learn all the collaterals and all the connections you have with anterior and posterior circulation. So anterior circulations, again, mostly the carotid tree and the branches, and posterior circulation, the vertebral basilar, and they are connected with posterior communicating artery. If I can point, oops, hold on, we'll point sooner or later. So see the mouse right there, that's the posterior communicating artery, And again, that's what's connecting between anterior posterior circulation. It's very important. It's almost act like a pressure gradient. So depending on how much flow you need anterior posteriorly, this can go either direction. Most of the time, this is not communicating, means that if you have a normal flow, you may not see the communicating arteries, only they just will open up if they have a role. Another important part of the anatomy, that when someone telling you the internal carotid artery doesn't have branches, that is awful. It's not true at all. And as you can see, the ophthalmic artery, which is taking off behind the eye, this is number 1 up here. There's a bunch of different branches of the internal carotid arteries. So sometimes this is why you find surprisingly that you have a proximal IC occlusion and you still do have an antegrade flow in an ophthalmic antegrade flow up here, because the vessels are reconstituted and the external carotid artery, the vertebral artery, able to give you collaterals and flow into the internal carotid arteries. One of the interesting thing is the anatomic variations are really the puzzle. So you really have to use some color map, or you need to use some nice figures, what you will remember very well in your so in anatomy and everything, that how you will compare your each image what you see on an ultrasound machine to probably a nice drawing which is from a Nether atlas, and you can see how the middle cerebral artery nice and long. Most of the time we see it from 65 to 40, so it's sometimes very interesting that when you look at an angiogram, this is an AP angio with a bunch of color and variations of the distal MCAs. Most of the distance we'll cover with a transcranial Doppler is about this much. You're not going to cover these branches up here. You're not going to cover the anterior cerebral artery up here. So you're only going to cover the main trunk, the M1 and the M2 branches. So M1 means always the main trunk on each vessel, and a vessel bifurcates, that will be M2. Same thing, A2, that's the ACA bifurcation after, so it's 2 branching. PCA has the same thing, P1, P2 segments, and we're going to go through that. And this is the P1 segment from the tip of the basilar, and P2 after the posterior communicating arteries. And it's also helps you to really learn sometimes when you read an MRI report trying to correlate with your ultrasound machine what the heck those reports are talking about when you see letters, numbers, and rather than just showing you on a picture, putting on an arrow there, that would be too convenient. Another interesting thing, I just want to go back to the previous picture for a second. So when you hold the probe here, believe it or not, from a lateral approach, this is your middle cerebral artery. So this is PCA, this is anterior cerebral. So when you're looking at, it's coming towards you, and this is why it's very interesting to see that you really have a minimal room to adjust to capture the MCA different part. The transcranial Doppler, different approaches, if you really look at it with the different study codes and the different CPT codes, means that what are the different codes, what are getting paid, and this is how you also need to know which TCD test you're doing. So someone asks you, hey, do this TCD, okay, which one? What's the diagnostic code, all those other fancy stuff. I think it's very important to understand that in the bad economy, TCD is your favorite, because carotid has 1-2 billing code for a limited one. Here's TCD has 4 billing codes, 1 limited one. So those are the things are very economy friendly, and each of these codes are pay more than the carotid code. So this is very important when you're leading any ultrasound lab or anything. This is why it's worth to do a carotid plus a TCD together. In our hospital, we try to really enforce the acute stroke TI. Patients are getting a carotid TCD combo as an order, and we show that there's a tremendous again improvement detecting disease instead of just relying on carotid ultrasound done for stroke patients. And I will show you why in a moment. So again, these are just the different approaches. One more time, one of my favorite window when you're going through the temporal bone is the posterior window. It means that you, front of the ear, if you just on yourself, try to feel this dent. There's a tiny dent just front of the ear, and that is where the bone window is thinner, and this is where probably able to capture the best intracranial signals. Again, you don't want to try and stick a probe everywhere. So the whole protocol of the TCD will teach you where to stick it and where do you point. So you stick it on the temporal bone window and angle up and anteriorly. Remember that picture again. We can go back and see, why do I enter anteriorly and up? So your probe is here, and you have to angle. This is the nose and the eye, so similar to this picture. So you need to angle anteriorly and up to really capture the MC and ACA. Angle posteriorly, you will get the PCAs. And the same thing on the sub-occipital bone window. You put the probe and the bone edge, and you point to the nose bridge. This is the plate. This is almost like the piece of paper, which is the circle of Willis sitting, and that's the skull base. If you can draw a line also from your ear to the eyebrows, if you're looking at that picture. So this is the plate where the circle of Willis is sitting. So from behind the neck, you just point to the nose bridge, and this is how you can see the vertebral basilar. The eye is tricky. Lots of people, and if you read papers and books, they're always saying suggest to start your protocol with MCA. I really changed my protocol by starting the ophthalmic and the siphon exam first, because that requires a little bit lower energy. So after you finish the lower energy part of the exam, so following the Alara rules, you can pop up the power, and you don't need to worry about changing the power, forget to change the power again, back to the power, blah, blah, blah. And also, second thing, to check the ophthalmic, you will have a clue if your carotid is occluded and what's the carotid status. So that's another important part, that the siphon signal needs to look like your MCA signal, and almost like you're prepared looking at the siphon, that how is the tip of the carotid and a carotid branch is going to look like as waveform wise. The eye is, you have a closed eyelid, and instead of going just a straight shot, you have 15 degrees lateral. And my idea is to really don't put any pressure on the eye. You just rest your wrist on the forehead, and you basically hold the probe on the side. So that way you're just holding the probe, and you don't you have a feeling that even with the weight of the probe doesn't put any pressure on the patient eyes. So let's see some. This is my fancy way to show you what is TCD frequency. So this is your regular piano. Has how many keys? I don't know, like 96, I think. Come on, Javier, you know everything. So you need to switch from a regular piano to a 196 key piano to really play the TCD. So that's how you, again, you need to learn a little bit of physics. I hate to tell you, I know that you're still in school. Physics needs to be there. So that's the wake-up call. The wake-up call is that anybody is talking about the blind TCD, I have a gun and I'm willing to shoot them. The TCD is not blind. The TCD has an M mode screen. M mode screen is a motion mode screen since the 2001. It means this century. If someone is talking about the blind TCD, that's maybe it's the last century or something, very, very old technology. This M mode screen able to tell you if the signal, the flow and the blood, again, the reflection of the ultrasound signal from red blood cells coming towards you, going away from you, and also tells you that how low resistance is the signal. See how continuous this beautiful red signal? That tells you it's a nice low resistance signal. Low resistance means when you just eyeball it, then you look at your end diastole, and your end diastole needs to be about 25 to 50% of your systole. That's my low resistance kind of criteria by eyeballing, and then we'll get some objective numbers for you. From a sub-occipital approach, I think it's really gorgeous when you stick a probe and you see the whole vertebral basilar. This is a lateral projection. of an angiogram, and this is how you see the vertebral basilar. The whole screen is blue, is gorgeous. Yes, because this picture is in the book. This is what we put in a book. Usually you're gonna see 1 or 2 centimeter wide of color signals, but when you're in a good mood and master, maybe you will find some good signals. Sorry, just hopefully that's a little bit better this way. If someone snores, just let me know. We'll wake them up. This is a 40-year-old gentleman, bilateral MCA. You can tell which side the carotid is occluded. This is again a gorgeous thing about transcranial Doppler that I don't want to know too much about my patients. I want to figure out what's wrong with them, and after, when I'm done with my exam, I go back and make the correlation with the previous studies. So here, that's obvious that your middle cerebral artery is a little blunted on one side. Another side, a nice normal middle cerebral artery and ACA. So again, the left carotid is in trouble. Why? Because when you lose your systolic upstroke, you know you have an obstruction between your measurement point and the heart. So systolic upstroke is not there. You're suspicious that you have a stenosis or narrowing between your measurement point and the heart. Doesn't need to be occlusion, just a significant narrowing or something, but it's definitely something we kind of have a feeling that we need to do a little bit more workup to see where the collaterals are coming from. So these are our objective things, and this is why we love TCD. It's a little bit new fashion. Carotid ultrasound is still old fashioned, and sooner or later carotid will grow up and will follow the mean flow velocity and PI values criteria. So the mean flow velocity tell you a nice advantage of how with one number you can describe your mean flow velocity. It doesn't need to have your peak systolic and end diastolic as a separate 2 numbers. Those are built in, and the machine automatically providing you a mean flow velocity. The machine, as a second number, the PI, also give you an idea how low, how high resistance is the waveform. The pulsatility index, PI, it tells you if the if the waveforms are high resistance and or low resistance. So here's an example. The low resistance is 0.6 to 1.1 PI values. You can see that there is a very nice fat waveform. If you go to this direction, which means your PI is very low, it means that your vessel is extremely dilated, and these are the extremely low resistance conditions, such as AVM, for example. In a moment you have chronic hypertension, or you're building up some resistance in your stiff vessels. Your increased resistance is going to show up, and in this increased resistance you see values to 1.2 to 1.6. And if the intracranial pressure or occlusion happens, you will see in an extremely high resistance vessel like this. Another beauty is not TCD can also show you a nice embolic signal. Maybe you saw it on a few duplex exams, but this is something really interesting that TCD able to pick up if something else is traveling in the bloodstream, not just the normal red blood cells or the normal cells in the blood. So some blood clot, a fat emboli, anything can have a different bright reflection. We call it high intensity signal or microembolus signal, and this is how it's show. You can pick it up, and later on we'll talk more about those microembolus signals. So submandibular approach, very easy. You just need to find and you need to see the low resistance signal, again about the depth of 50. And it would be a nice blue signal, because the blue signal means going away from you, and this is why it's nice low resistance. This is the exam through the eye. So through the eye you're supposed to see an ophthalmic artery at 50 millimeters, and 65 to 70 you see the siphon. What is the difference? That this signal is so intermittent, so in diastole there's not much of the velocity. Why this one you see a nice continuous really weak signal, but it's low resistance here. So this is ophthalmic waveform, high resistance, low resistance siphon. And what does it tell you? Low resistance because feeding the brain. Why this is high resistance? Because it doesn't feed the brain. This is how simple that you know that the ophthalmic again is just not part of the brain that much, and it's a really small vessel also compared to the siphon. So you need to think always the resistance of the vessels as how they really built the resistance in the peripheral side. Actually, I want to show you some fancy stuff. I just were giving a talk to our poor fellows and residents about the hemodynamics, and probably you know a lot about high resistance and low resistance, but I want to show you this cool stuff. So this is basically a waveform. Waveform captured by transcranial Doppler, systole to systole. When a yellow line is, this is your end of systole, and that's your aortic valve closed down. But when you look at the top where the blue arrow is, there's a damping inside your systole waveform. See that? So it means that the heart is pumping, 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 and the flow suddenly say, hey, I'm not increasing anymore despite that you're still pumping, because I met the peripheral resistance. So the resistance from a distal shuts down, and this is why you have a peak systole. If you wouldn't have a resistance in the peripheral arteries, your velocity would be 400, 500 centimeters per second. This is what the heart can pump out. So the difference is what is the 1/5 truly what your velocity is, and when you meet the peripheral resistance, then it shoots back. So the vessel dilates a little bit, and that's your elasticity kind of dipping down, so velocity drops a little bit. And the second peak is, this is what the vessel elasticity provides, pushing the flow a little bit more further. So chronic hypertension, this curve is gonna be nice and curved on the top, because the waveforms again will show how much resistance in the vessel has, and this is how you can really see, not just in the systole, but in chronic hypertension, you're gonna have to lose a little bit of the diastolic too, because again your resistance building up and doesn't need that much of the flow. So very important, again, we're talking about brain needs to have low resistance flow. In a moment you see something high resistance, first you think about hypoplastic vessel, small vessel, quite common. ACA can be small, vertebral can be small, but those suddenly gonna be a higher resistance signal. I'm not gonna talk to you about that waveform because it's really fancy. Have you guys seen an intra-aortic balloon pump? No? So when you're working in ICU and your heart is not working, we put a balloon in the aorta trying to help and relax the heart. And in this case, this is your EKG, and here's your heart line. Every third heartbeat, we have a balloon inflating and forcing one more flow to the through the carotid. So this is 1, 2, 3. We can do one every second or every heartbeat. So this is how we can change the waveform. And why the waveforms are going to be exactly the same height? Again, because they meet the resistance. Doesn't matter who is pumping, but the resistance is going to give you how far they can go up. Sorry about the extra tour. Go back to the eye. Any questions so far? Ladies, please. You don't want me to start those questions, trust me. So let's see that your carotid is occluding. In a moment you have a carotid occlusion, what you're gonna see through the eye, sorry. So the signal, instead of red, is going to be blue because your flow is going this way. So the carotid is occluded here, so your flow can come up here towards the brain. So it's gonna be one of the collaterals going to retrieve is the ophthalmic. From external carotid branches, the ophthalmic artery will be reversed. But even if you're color blind, you have to notice one more thing. What's the difference between the ophthalmic here and the previous slide? Resistance. Did you guys hear that? So speaking, ladies, I want you to yell resistance. So not just the direction change, but also the resistance, because now you are feeding the brain. So you're no longer feeding the eye. That's why the resistance going to be changed. And again, not just red, change to blue, and underneath the zero line instead of above the zero line, but also it becomes more continuous on M mode and nice low resistance here. Cool? Very easy. Takes about 2 seconds to do that part of the exam. To stick it on the eye and you see antegrade, ophthalmic, or retrograde.
And you don't have to turn the power down on your system to go through the eye, or you do have to?
Yes, I do. This is how I started, and that's my reasoning behind why I'm starting my protocol with the eye exam. So I'm starting with the lower power, and then for the second part of the power, I just pump it up, and this is how I do it. So the protocol after the eye will be 3 MCA, ACA, PCA. That would be, again, not just one measurement in MCA, but you need to do at least 3. Why 3? Because you don't want to miss any stenosis between. Second, again, MC is long enough that you're able to see and predict something if it's even distal disease at 45, but you won't be able to predict this much distal disease just at the origin of it. Then ACA and PCA. So these are what you capture through the temporal bone windows, and these are the beautiful screenshots. These are not paintings. These are not. These are really like screenshots from the machine, and this is how gorgeous this ultrasound can be. And one thing is true: if you have Parkinson's disease, please don't try this, because you really need to have a really steady hand. If your hand is shaking, take some beta blocker, get some scotch. Those are the things kind of helps that your hand is not shaking. So the whole idea is that in this case, I would not move my hand at all. I would just need to change the depth to listen to all these color signals. So the whole art is not to do the painting job with your probe like all over the head, and not to go all the way to the top, but just kind of stick it one spot and don't move. Then the left hand will do the job changing the depth, and that's how beautiful you can see. This is again middle cerebral artery, blue is anterior cerebral artery, and the midline is about 70. So this is the contralateral ACA, this red signal. And on the bottom you see a little bit of blue. You see at about 80. That's the contralateral MCA. You can see a little bit of blue here. I hate to tell you, on my screen is so much nicer. Somehow it's just a little bit too dark, but a little bit of blue here. So, just for example, so which is a bigger head, this one or this one? Which is bigger head? So what we are doing is I give you, feeding you any information. I told you your midline is 70. Okay, so you have some information, and then I have a nice indirect question, seeing that if you're learning something or you have any knowledge that why you think the midline is in this case. If your MCA, ACA is down and you don't see that much of the contralateral ACA, so this must be a huge head because your midline is about 80. So the whole thing is that you have to think why you're doing this TCD. This is why it's very dangerous ultrasound. You have to think. It's not enough just to watch it and take pretty pictures with the duplex. Here, you really need to think why you're taking pictures and saving it and trying to put it together, because your interpretation is going to be so crucial to see what's the finding and the final interpretation of the test. Here's another beauty. Let's see the PCA. PCA means that through the temporal bone windows, I'm pointing a little bit more posteriorly, and I'm going to see the P2 as blue and P1 is a little red. You can see this part. And why you don't see too much of the blue, because sometimes you just have weaker signal, but if you really want to see the nice blue, is this one. I can invert the spectrum so you can see the negative number above. So good thing is you cannot invert blue above, so it's what's blue is blue. So on a duplex machine, this is why you don't have a reference color box on the side or anything. So here everything blue going away from your probe, red is coming towards your probe. Second thing, I just wanted to really fake it, and I put a wrong vessel label here. So that's another danger of the TCD. You need to label your vessel. If you don't label it, then you need to call Sherlock Holmes to really help you out, because nobody else can really figure out what the heck you saved if you don't have a good vessel label on. The only thing can help you sometimes, that this is a venous signal here. So this venous signal runs together with your P2 branch. It's called the Great Vessel of Rosenthal, and this is can be your best buddy when you're reading TCD and you have a wrong label. So PCA, and then finally let's go back to reverse basilar, because this is my favorite. We are missing so many diagnoses in the vertebral basilar, and I think the vertebral is way underrated as disease-wise. All your syncope patients and all those patients who are falling, and you're doing carotid duplex on them, so they need just a vertebral check, because I don't think anybody gonna fall from a carotid stenosis. So here's the beauty. What I want you to do is put this picture together, that your probe is behind the head. Look at me. Behind the head. This is a lateral projection. So the angio shows you how the vertebral basilar looks like. Okay, look at the screen now. So here is your vertebral. First branch is pica. This is entering to the skull. And then you see here's the basilar artery starts about 80 and ends about 100, 110. So anything you see like branching off, those are these really red signals. So the main trunk is blue, going away from your probe, but the main tiny branches can be red because it's coming towards your probe. Cool? Second, you see how the main trunk is a nice long color segment, and your branch is just a tiny one? That's another way to really differentiate which is branch, which is main trunk. And if this is what is gorgeous and everything is blue. So then this is the trick. You ask the patient to turn ahead and put the chin down. Remember how the vertebral basilar, let's go back. Remember how the vertebral basilar has this like 140-degree turn? If you ask the patient turn ahead and put the chin down, they're gonna line up this whole vertebral basilar for you. So you, with the head positioning, you're not changing anatomy, you're just kind of a little bit faking it and kind of making it more convenient for you to study, and you able to see this whole screen blue, and that's the awesome part of it. Okay, I want to show you a study from beginning to the end. So if this is, again, try to really keep it for you truly basic. And when you have a nice basic ultrasound, you need to have a nice report as well. And the machine automatically does this report for you. So you need to select which picture you would like to save it for the report, and then it's nicely grouped. So you can see on the right side, right MCA, ACA, PCA vert, left MCA, ACA, PCA vert. You can see the depth where they were recorded. You see the mean flow velocity, and you see a PI values. What's RI? How do you calculate that? Well, it could be Research Institute too. This is why I was asking, make sure that you know it's registered. Tell me again.
Is it max minus minimum over average?
That's perfect for PI. I just showed you the PI.
Over max. Okay.
Over diastole. So, because we are teaching, let's go back to that slide. Remember this one? So that was your average. So you cannot use the mean. So what would you do? RI would be peak minus end diastole divided by end diastole. So this is why PR and RI kind of similar numbers. Everybody, we call a PI used in the US, RI used in the peripheries and more in Europe. I don't know. I just always have those things. If it's listed on your report and you see those numbers on your screen every day, you just want to know about it. And let's say that the machine failed to calculate, you can kind of figure out yourself how to calculate it. So this is the first page, and additional pages will show you all the other beautiful pictures you took. So we're gonna do it from beginning. So this was the study. Started with the right eye. I see the ophthalmic, and I see the siphon. Okay, this is not for book. This is real life. So the patient is talking. That's the talking. Okay, this is not a brewery. This is not an artifact. No, it's just a patient voice. So when you do it through the eye, see your ophthalmic. So which part of the siphon is this? Remember, the siphon has like a turn. You can see one part coming towards you. This is going away from you. So this is why what's above the zero line is your ophthalmic, and what's underneath the zero line, that's your siphon. Kind of makes sense? Okay. Left eye, just the ophthalmic and a siphon on one shot. And this is again an advanced level. This is why I'm not go and listen to the ophthalmic. So that's one more reason I'm saving energy and saving time. So when it says alara, alara means as low as achievable, as reasonably achievable. Hey, if I'm on 100%, I'm spending 5 seconds on the eye. That equals you are massaging with 15 minutes with the 10% power, right? So this is the difference. That if you see the screenshot, this is 4 seconds, okay? I'm not cheating. Look at the right upper corner. Tell you how long this study takes. 1340, 26 seconds. 30 seconds later, I'm already done with the left eye. Another 30 seconds, I'm already in an MCA. So definitely I spent less than a minute on the eye, and notice the power was 30. So with a power of 10, you have problems seeing the siphon, then you pump it up to 20 or 30, and you're still limiting your time, how much time you're going to spend on the eye. But after that, you will go up through the MCA, and you will see the MCA with 100% power now. So mid MCA, distal MCA, proximal MCA. So do you guys know what's the proximal and distal means? What's your reference point for that? Heart. So which is closer to the heart? So middle cerebral artery origin is 60, distal is 40. But if you talk about the basilar, see, here's your vertebral basilar. It will be proximal 80 and distal is 100. Cool? So it's kind of reversing, which it doesn't mean that whichever distance is bigger, that's going to be proximal. Oops, Karen. So that meeting never happened, sorry. Just one of those computer stuff. Okay, MCACA together and a PCA in a moment. This is a gorgeous flat venous signal again. Your vein helps you that you know this is not MCA, this is a PCA. And that's how you can fake it again. You can change the label, and then if the correct label, I think you're going to be so much happier. On the right side, you see the mean flow velocity and the PI values. Those are the good numbers to follow. Okay, we are on the other side. Again, I hate to tell you, 44, okay? Go back when we started the right side. 42. Guys, 2 minutes. If someone's sitting on an MCA for 20 minutes, they didn't have a training, didn't have a clue what the person is doing. Those are the things that are very important, that when you learn your protocol, you know where to point, how you push save button, and this is how you're not going to cook the eye and you not have a boiled egg at the end. And again, the danger, yes, you can have cavitation in the brain and all those other fancy stuff. We have a microwave in our hands, and this is why it's very important that you limit your study and you're quick. Left side, distal, mid, proximal. Okay, let's see it one more time. 44:25. I'm not moving my hand. Done, done. Did you see that? I'm not cheating. This was like 20 seconds. You're barely just pointing, and you know, even you think about moving, that's how much movement you need in your hand. ACA, PCA. Okay? Then we're going for posterior circulation, vertebral first, Then we follow the vertebral. Here's your proximal basilar, mid basilar, a little bit of weak signal, and distal basilar. If you see it on my screen, there's a little bit of more blue than here. You see the little blue there? Okay, and then finally you go to the other side and you see the left vertebral. So the whole idea is to complete the study. Bilateral exam means eye, temporal, and suboccipital approach. So 3 approaches at least. Again, the submandibular, we just leave it for the ICU. So this would create about 20 pictures, and when you go back on the report, you probably have about 1916. And one more thing, let me go back to the report for a second. What I like about the report, that it's 1 page, and here I can put my text here. That will be my report front page. All the additional pictures, what you see here, those are just a save we went through as a screenshot, and this is how you have a vertebral and a basilar at the end, and it keeps you as it was in your protocol. So let's see some abnormal stuff. Do you guys want to see some abnormal stuff? So first thing we're going to learn today is called the term flow diversion. FD, not fire department, but flow diversion. It means that if you have a severe stenosis in MCA, it's going to divert the flow into the ACA. MCA always the highest velocity, and on this picture you see the ACA underneath the 0 line has a higher velocity than your MCA. So this is what you see, flow diversion. And what you will see the next moment, that this bruit in systole, that's your mark for stenosis in a middle cerebral artery. When you move your yellow line up there, you see the increased velocity with a bruit, and that bruit is the turbulence which giving you the deleted signal on the motion M mode. Okay, one more time. This is called M mode, power M mode, motion, and this is the spectrum waveform. And whenever you choose the depth, the yellow line or green line, that's what's giving you the measurement. So the velocity measurement is happening on the bottom of the screen, not on the top of the screen.
Can you show me the other one and that one again?
This one?
And the one right before it?
This one?
No, I'm sorry, that was
Which one? What do you want to see?
the one you just showed and the next one.
This one?
Yeah.
And this one.
Yeah, okay, thank you.
So what I wanted to show, this is the same patient, and between them we'll go to the next slide for a moment. But see, this is a proximal MCA, MCA and ACA together. So the red one is the MCA, the blue one is the ACA. So I don't care what's the number, I just eyeball it and looks like it's a double peak. So this case, it only shows the velocity above the 0 line. So this is the stupid machine, doesn't tell you 2 velocities at the same time, but kind of you have to have those 2 measurements done, and that way you will see it. Cool. So you move your yellow line and you go out to that depth where there was that turbulence, and this is how you capture the stenosis. So what's the other occasion how we can have flow diversion? So this was the MCA stenosis. The other thing, when AC is higher than your MCA, could be if you just have an ACA stenosis. And one more, which is very, very nice and indirect. If your ACA is higher than your MCA on this side, because you have a contralateral ICA disease, and the AC is going to feed the contralateral side. So that's a sign of the collaterals that you have a contralateral ICA disease, that your AC is higher than your MCA. So I'm teaching you direct and indirect stuff, so that way you were able to go through it. So another thing is that when you see turbulence and bruit, and not gonna be all the time stenosis. So the mean flow velocity, a normal value, needs to be less than 80. You can see books giving you each vessel has a normal values. You can kind of forget about that one. You just say mean flow velocity is normal for each vessel between 20 and 80, because it's so much depending on a patient age, depending on the blood pressure, depending on hematocrits and all those other levels. But in this case, you have a turbulence, but your mean flow velocity is normal, because you may have a young person and you have maybe a bifurcation here. That's what's generating this turbulence. So not all the time when you see this intermittent signal in systole will be disease, but that's just one more example that the mean flow velocity needs to be increased for stenosis. Yes, that's a beautiful stenosis. Your mean flow velocity definitely up to 200s. Your peak systole 300, end diastolic is 150, and you have this nice beautiful bruit, almost like a musical murmur here. What happens when you don't have diastolic flow? Oops. Yeah. Sorry. So when you don't have diastolic flow means that you're not perfusing that vessel. Means that's an occlusion. It means that you can have a flow diversion here too, that the occluded vessel, the red, which is the mean MCA, is going to shift the flow into the branch. That's why you see the blue signal and underneath is higher than what's above. So every time you see the mismatch of these waveform like this, you can think about there's occlusion or stenosis or something, definitely why there's a huge mismatch between a branch and a main vessel. Okay? So what we try to show when you see disease, systole, you have a problem, that's a stenosis. So stenosis, systole, bruit. When you have a diastolic flow gap and you have intermittent signal on M mode and you don't have diastolic, you need to think about occlusion and obstruction. And this is how we grade stenosis on TCD. Nice and simple. You need to have a velocity increase in the same vessel segment. If your velocity doubled, 50% stenosis. If a velocity 3-4 times, that's the 70% stenosis. Cool. Everybody knows about the Spencer-Reed curve? Uh-oh, too many shaky head. So, the grading of carotid stenosis or grading of any stenosis, these two gentlemen built a pipeline, and these pipes were, again, not blood in it, but some gelatin, and they had some, again, because it's happened in the end of the 60s and 70s, or maybe published in 74, so it had to be maybe not pulsatile wave, but continuous wave Doppler. But what they did, if you don't have any obstruction on the vessel, you have nice normal flow. And this is how the degree of the stenosis and the diameter reduction goes to the total occlusion. On the other side, you see the area cross-section reduction. And you follow this curve. This is how the velocity is increasing, depending on how much diameter reduction you have in the vessel. In a moment, you reach about 70%. Suddenly, we call it hemodynamically significant stenosis. Why? Hemodynamically significant because your flow volume is starting to decrease. So your flow volume going down. That's the sign that your diameter is not enough anymore to deliver the same volume. So that is why we have 70% hemodynamically significant lesion. Someone can have that 50%, whatever, depending on how much collaterals you have also distal. But the whole idea is this is what tells you that the flow volume starts to drop. That's a hemodynamically significant lesion. Your velocity increase, and when you have an ear occlusion, it starts to drop. So the whole idea, if you have a velocity of 300 centimeters per second, how do you know which side you are at? On this side of the Spencer curve is 70%, or you maybe have a 95% stenosis with this side of the Spencer curve. Then you go back and say, aha, this is what's going to help me. If my velocity is 3-4 times, we are in the 70% range. If my velocity has a huge drop, like 8 times drop distal, so again, stenosis needs to be a focal. If your velocity is increased and you have 90 centimeters per second mean flow velocity throughout the whole vessel, that's hyperemia. So it's a focal velocity increase what's confirming that this is a stenosis. So stenosis is always, you're going to find just one spot when your velocity is increased. You're not going to find increased velocity throughout the whole vessel. Why? Because if you have a diffuse disease and a very long stenosis, your velocity will drop. Cool? So if you have a short stenosis, this is why hemodynamically you will see the velocity increase. If you have a 2-3 centimeter long clot or very long stenosis, you cannot have an increased velocity because it's so long, that vessel piece, which is stenosed, that it's ultimately going to just have a low velocity and drop, and all the ratio going to help you to figure out why there's a drop in velocity. So this is how when old-fashioned TCD reports are generated. First I came to Houston 2001, and this is how we were doing the reports, believe it or not. Piece of paper, this is our drawing, and a piece of paper we just wrote down mean flow velocity dash pi. Mean flow velocity dash pi. So negative means ACA, negative flow. So this is how we generated our handwritten reports for a while. Rule again, MC is the highest velocity, biggest vessel, and it supplies about 80% of the brain. So that's why velocity is increased, but also the volume is delivered, a lot of volume. Okay, this is when we are talking about a little bit more abnormal signals, and you need to kind of remember this one. TB, thrombolysis in brain ischemia, is exactly the same copycat word what the cardiologist using for a heart coronary occlusions. Thrombolysis in myocardial ischemia, TIMI and TB. These are the grades for the occlusion of the vessel, and what we try to do is on your TB flow grades, we want it to match. What do you see on an ultrasound? So when you have a dead normal flow or a little bit of stenosis, these are TB5, TB4. So we have a really nice way to communicate how bad is the occlusion if you say TB2, TB3, and also it's easier to follow up those patients over time with treatment. When you have a partial occluded vessel, so not everything is occluded, but one branches or two, then we call them blunted or dampened, TB2 and 3. This is depending on if you have systolic upstroke or not and how much velocity you have. And when you have a total occlusion and you have not much of the flow able to detect, you don't detect any flow at all, versus a tiny flow when you have no diastolic, this is a TB1 grade. So these fancy words, why it's important, because we made this up extra next door at the University of Texas Houston while we worked in the Herman Hospital stroke team, and those are all the publication on TCD you're gonna find. This is Dr. Grota, still the chairman of neurology and a stroke guy next door, and with my Russian colleague Alexandrov, we did this fancy work when we figured out how ultrasound is going to even enhance the effect of thrombolytic drug and able to improve an occluded vessel and reopen these vessels. And this is again the TB grade tells you how far you are away from an occlusion, and this is something that we're using every day. And the whole thing started as a nurse reported that, you know guys, when you're doing this fancy thing on the ER on those patients, they are doing better. When you guys are not around, we're just treating them with IV TPA, they are not doing that well. So based on that simple message, we came up with this protocol, and during the TPA, we did monitor this patient for 2 hours, and with the head frame placed on the head, so the probe is not moving anywhere. So you don't have to hold the probe basically, but for 2 hours, the delivering a nice ultrasound energy looks like shaking up the clot a little bit and improve these patients. And this is my very first MC occlusion I detected in August 01. 33-year-old gentleman comes in after playing basketball, and this is the occlusion in MCA. See, high resistance, there's no continuous red signal, the blue is there. That it tells you that the ACA is open and only the MCA is occluded. What would be the color if your IC is occluded?
Blue.
Blue, no. So, let's go back. ICA is occluded. What would be the color of the ACA?
It's red to begin with. It's red.
See? This is how you're gonna learn something. This is how you're gonna learn something. I don't know what you're gonna learn, but something. Hold on, I'm gonna show you. Maybe not. Yeah. Here you go. So, MCA red, ACA is blue. Cool? Now you compress or occlude your ICA on that side. What you expect to see that the ACA is unable to deliver an antegrade flow, so the ACA needs to reverse to able to bring flow from the other side. Yeah. So it's going to be red. So that's the scenario when you simply can tell, oh, ACA blue or red tells you the status of the carotid. Stick the probe on the eye, tells you the status of the carotid. This would be my game that if I do a TCD on someone, I do not need a freaking carotid ultrasound to tell what's the status of the carotid if you are good with your TCD. So that's when you have a stroke and TIA patients, you don't need a carotid ultrasound, you need a TCD. Why? Because the brain is an end organ. Doesn't matter if you do a carotid massage or not, you really want to see what's the flow in the brain. And that's what tells you that what's the pipeline is bringing up, you can tell from above. So you're looking down on a carotid, there's nothing coming up because the other side is feeding my ACA, and that's simple how you can go back and get this. Cool? Questions? I so want to hear some questions.
If there was no communicating anterior artery, then you would expect to see no signal there, and that's how you would know? Or what would you see, like say if it was hypoplastic, you would just see a small signal? You know, how could you tell that?
No, I don't.
You do.
No, I